I think this is really a great place to move from the adjuvant discussions. You know, sort of the excitement of adjuvant therapy is that you're curing some patients, but the difficulty, partially as the physician, is you don't know who you cured and who you just gave toxic therapy to and didn't have a benefit. The oligometastatic disease is one of those very rare places for a medical oncologist that you can feel you were part of a cure and know it. So looking at, here are my conflicts of interest. This is a case just from earlier this month. In the hospital, a lifelong smoker presented with new gait disturbance. Brain MRI shows a right frontal mass, and he went straight to craniotomy. Squamous cell carcinoma, CK7 positive. There was patchy TTF1 positivity. We'll get to that in a second. EGFR and ALK are still pending, actually. And so while in the hospital, he had a CT that showed this very small left upper lobe lesion. They didn't think it was really clearly the primary, but able to get an in-hospital PET, which showed that it was quite hot. So what next? I don't know if anyone wants to call out, but certainly there were some different thoughts about how to approach this. And the hospital team decided to pursue a biopsy of that left upper lobe lesion, which I think was very appropriate. Actually showed adenocarcinoma, so presumably an adenosquamous. Oh, sorry, not quite there. Can you go back one quickly? So we got thoracic surgery and radiation oncology involved and discussed the situation with the patient. I say otherwise healthy. I guess he had coronary disease and a heavy smoker, but he looked okay, and wishes to do everything. So now what next? And I think we have a vote. Oh, I seem to be having trouble here. So any thoughts on this? I think what makes this interesting is it's hard to say that there's a right answer, but just to end with a little discussion if people want to. So oligometastatic lung cancer, the first I was able to find this term given was 20 years ago. Hellman and Weichelbaum in a JCO editorial described oligometastatic disease, and actually they've recently done an update. Basically, the idea that there's a spectrum of disease. Some had considered that you have a primary that then grows to the local lymph nodes, that then goes to more regional lymph nodes, and then metastasizes from there, where there's other disease that may be more widely metastatic, even from initial presentation, and that there's a spectrum between those two extremes. And as they described, I think, well, an attractive consequence of this concept is that some patients so affected may be amenable to curative therapeutic strategy. So across tumor types, colon cancer is probably some of the best examples. About 25% of these patients, highly selected, very important, but 25% of them may achieve long-term survival. So how can we identify them? Not surprisingly, oligometastatic disease in many cases, those patients do better than widely metastatic disease. Several studies have reported that. Dr. Albane had a report of multiple prognostic factors, and one of them was that metastases to a single organ did better than metastatic disease to multiple organs, not surprising. A very long accrual of patients from a Harvard group described 186 patients over 10 years with a limited number of metastases. And some of these are instructive. I think ECOG of performance status, of course, matters. N2 and N3 status is important, and I think that goes along with my experience as well. Squamous pathology tend to do worse, and multiple organ involvement did worse. And interestingly, the tumor size and the specific number of Mets, not the organs, but the number of Mets were not prognostic. And in this setting, retrospective, not randomized, the patients who had local therapy to primary tumor had a significantly improved overall survival. So an important concept is that there's multiple different oligometastatic states. I've mostly been talking about at the initial presentation with a limited number of metastases, but you could also consider a patient with more widely metastatic disease that gets a CR at all but few sites. which I would think is probably one of the poorer prognostic groups among these. Relapse to a limited number of sites. This is among the best prognostic group. Patient who, sometimes a long time afterwards develops a single metastasis. We will often resect that and hope for another good long disease-free interval. And then oligo progression, which has been mentioned a few times. I think most important on targeted therapies, generally good control, but a site of progression. When we consider ablative approaches, patient selection is important. I think these are all sort of what we do naturally, but just to codify it, good performance status, long disease-free interval when you're talking about those oligo-recurrent patients in a limited number of metastases, and then the systemic therapy that we're going to add to it. And I think that's where some of either the art or the difference of opinion may come about. Where do you put in the systemic therapy, and how do you weigh chemotherapy, targeted therapy, and now predominantly on trial immunotherapy? At UCLA, and I think that probably many others do this, but I just want to acknowledge that not all of this is evidence-based, but just our practice pattern, is we tend to often they're presenting due to a symptomatic metastasis, as in the case that I presented, so resecting the MET, reviewing the goals of care, and the patient's performance status, often then going to systemic therapy while the patient still has the primary intact, and evaluating for progression. If you go on systemic therapy and they immediately progress or develop new metastases, you've avoided doing a toxic intervention that would have had no benefit. And then if all goes well, then going to resect the primary, and then follow for recurrence. And sometimes a limited recurrence could again be treated with an ablative technique, either surgery or often stereotactic radiotherapy. So a special case is in lung lesions, and I think these are often some of our more complicated tumor board cases. When you have perhaps bilateral lung lesions, you're trying to distinguish, are this oligometastatic disease, or are these separate primaries? In that situation, we often at UCLA use the lymph node status, even if there's bilateral disease, but lymph nodes are negative and it's a highly, a good performance status patient. Sometimes we will try to resect bilateral disease. And I think I don't know how useful these CT scans are, but in the top case, this is a patient I've been following for many years now, actually. Interestingly, one of these lesions was EGFR and KRAS positive, another one was KRAS positive, and the third one was a different KRAS mutation positive, showing how complicated some of these cases can get. But even though you see these three in this slice, there's really no other disease. In comparison, the other patient, as you scroll forward and backward, just lesions are showing up all over the place. So I'd like to distinguish those as different cases, and really the lower case should be considered, I think, M1A, really widely metastatic disease due to intrathoracic extent. So going back to this patient, I don't know if we need to vote again in the interest of time, but what do we do next? And so what we at UCLA are currently for this particular patient discussed with radiation oncology, a short course of radiation to that tumor bed. I don't know if you remember, but it was a pretty large, extensive tumor with a lot of surrounding edema. So really did not want to get a local recurrence of that lesion. So doing that first, then planning on proceeding to a platinum doublet chemotherapy, likely with CT imaging at 6 weeks, and then if we're really still considering an aggressive, possibly curative approach, I would restage with full PET scans. As was discussed, I don't typically follow with PET scans, but I think when you're really considering a major intervention, it's appropriate, of course, repeating a brain MRI at that time, and if all looks well, considering a left upper lobe lobectomy. So hope I've gone quickly enough, but these cases can get very easily complicated if you're looking at EGFR, ALK, and ROS1 mutation. I would say that while the response rate is high, that as has been said, TKIs have no clear role in neoadjuvant or adjuvant therapy in a potentially curative situation. So if you are really going for a cure, I don't see much of a role for them. However, you sometimes will have to weigh sort of the difficulty of an aggressive, chemo, radiation, surgery approach when you could just put them on erlotinib and expect a good response. And these are some of the most difficult cases. Often, for me, often can even have regrets afterwards, but worth spending a lot of time with thinking about. And then, as mentioned before, oligo progression, several studies, I think probably the best reported was out of Colorado, showing with EGFR and ALK abnormalities, what they called a PFS2, a second progression event, can be delayed on average 6.2 months, but some patients even significantly longer by radiating. In their case, I think they have some up to 7 sites of progression, but in my experience, often with a couple sites of progression can be treated, and then continue on the TKI. So the last one that I think is really sort of at the edge of practice these days is immunotherapy and oligo progression. How do we treat that? We have at UCLA not had a lot of success with trying to resect a site of oligo progression, and instead have looked more at radiating that, but quite complicated on a clinical trial at times. And then, when these drugs are approved, and perhaps if they go to the first line, we will also have to weigh, maybe patients would rather just go on an immunotherapy than go through these very complicated regimens. So in summary, there's a spectrum of disease, and perhaps not all metastatic non-small cell lung cancer is widely metastatic. Each patient has to be carefully considered, and certainly a multidisciplinary approach is crucial. So thank you very much.